this time, I'm going to I introduced him a little bit earlier, Dr. Omar Samad, who is a PhD doctor, but he works for Esai Pharmaceuticals, which is one of the companies that has developed the newer drugs that you've heard something about in terms of treating Alzheimer's dementia. But Esai is a pharmaceutical company that provides a lot of money for clinical research, not only in Alzheimer's disease, but also hypertension, diabetes, and strokes. As Dr. Goldie said, research into different chronic diseases is a very costly enterprise. And it's not something that's just borne by our academic partners, the Emorys, the Mercers, the Harvards, the Yales, the Stanfords. A lot of the cost of research is paid for by pharmaceutical companies, and not just because they're trying to sell you something. So at this time, I'd like to bring before you Dr. Omar Samad from Esai Pharmaceuticals. Dr. Samad.
Thank you, Dr. Parker. Well, first of all, Dr. Parker, thank you very much for the kind invitation. It's a privilege to be here with you today and talking to you about our new drug. We're very excited about. It's also an honor to be presenting in this prestigious room. So again, thank you. So what I'm going to be talking about here is a new treatment option for early Alzheimer's disease. And my disclosures are, as Dr. Parker mentioned, I come from Esai, so this is the private sector, it's a pharmaceutical company, and I'm in the medical affairs department. So I'm not, like Dr. Parker said, I'm not trying to sell you anything. I'm in the medical department. So just a couple of, points before I start. So the intent of this program is really to provide you with information about the new drug that Dr. Goldie mentioned a little bit. It's a treatment option that just got approved for Alzheimer's disease. It's important to know I'm not here to provide any specific medical advice, and it's very important that you speak to your doctor about any questions you have related to Alzheimer's disease or your condition in general. So with this, let me introduce to you the new drug. It's called Leqembi. And I was told, actually, for our company, why they chose this name. So the LE is for the first two letters of the molecule's name, which is called lecanemab, and Kembi in Japanese means healthy something along the lines of healthy, beautiful. So they put those two together and came up with Leqembi. So as Dr. Parker mentioned, Esai is a Japanese company, hence the Leqembi, the Japanese. So I'm here to talk to you about this new drug, Leqembi. So what is it? For what patients it's used? And also some of the safety considerations that are very important. So it's here, but I'll briefly go over. So what you need to know first is that this is an approved drug for treating Alzheimer. That said, not all Alzheimer patients, as you've heard and as you know, there are several stages in the disease. This drug was tested in the early part of the disease. So this part called mild cognitive impairment due to Alzheimer or mild dementia due to Alzheimer, not moderate or severe. It's very important that this does not cover all of Alzheimer's, it's the early Alzheimer. And I can address any questions about it later. So the second point is that what you will see on all of my slides, this section at the bottom, which is important safety information. It's there, as the name indicates, very important. One of the very important things you need to know about lecanemab, about Leqembi, is that it has a boxed warning when you see it on the label, and this is due to amyloid-related imaging abnormalities, or they're called ARIA. What are they? Those are basically the areas of damage, of small damage to the brain that you see in imaging, in MRIs. and they could appear as dots or could appear as, you know, a little bit of brain bleed or a little bit of swelling, you know, you've heard in the talk earlier. And so imaging related, because they are seen on imaging, they're not always symptomatic. Actually, mostly they're not symptomatic, but some of them can be symptomatic and can be very serious as well. So when they are symptomatic, some of the symptoms that you see are, so you see them listed here: headache, confusion, dizziness, visual changes, nausea, difficulty walking, or seizure. So when these things happen, of course, it's very important to talk to your doctor about. And we'll be talking a little bit more about this. So this is a slide just to give a little bit of an introduction about Alzheimer's disease, although you've heard from the expert, Dr. Goldie, about it, but I'll just walk you through this slide briefly. So Alzheimer's disease is a type of progressive brain disease that can cause problems in different areas of our life: memory, language, and also thinking. And that could affect also our functions in our daily lives. So how do we test for those effects of Alzheimer? So what your doctor will do is kind of specific tests that they do, that look at your memory, that look at some aspects of your function, some aspects of your critical thinking, and even some aspects of your activities of daily living. And all of those are tests that are done in clinical trials, and they provide the basis of finding out whether a drug works or does not work based on those tests. And so again, like I said in the previous slide, you could see the important safety informations that are listed here, which we will continue to talk about. Okay, so now moving on to what is lecanemab. So this is a prescription medication to treat people with Alzheimer's disease. Although I have to say, like I mentioned earlier, the patients who were studied are early Alzheimer patients, patients with mild cognitive impairment or mild dementia due to AD. And so what does mild cognitive impairment really mean? And I'll move here a little bit because the screen is a little bit, I can't read. So what mild cognitive impairment mean is that this is when the symptoms like forgetfulness or confusion are mild and may not really interfere with your daily life. So this is that stage called MCI. You'll hear a lot about it. Now, the other group of patients are patients with mild dementia due to Alzheimer. Now, what this refers to is that when the symptoms like trouble keeping track of bills, trouble doing daily activities that you used to be able to do, and then that usually at this stage, we will see patients start to need some assistance in their lives. So, like I said, these are the populations where Leqembi was studied. Of course, patients should not receive Leqembi if they have a serious allergic reactions to Leqembi, the molecule, or any of the ingredients that is in the drug. And so before receiving lecanemab, you, of course, have a conversation with your healthcare provider to talk about the medical conditions, including, but not only limited to, if pregnancy or any other conditions that are not listed here. So what causes Alzheimer's disease, and how does lecanemab targets this disease? So what causes Alzheimer's disease, and again, you've heard from Dr. Goldie, this is just a reminder, there's a continuous buildup of these proteins called amyloid proteins that can cause the Alzheimer's disease. And this is a continuous process that happens over many, many, many years before the onset of the clinical symptoms. So what you could see, presented here is that you see that these proteins starts to accumulate, Then there's more accumulation. They start as kind of soluble, then they start to aggregate more and more, become insoluble, and eventually become these amyloid plaques that can be seen with imaging, PET imaging, that you could see. And then you saw some of the pictures that Dr. Goldie shows. And so so people with Alzheimer's disease have this protein, like I mentioned, that starts to accumulate and clump together into larger forms that becomes the plaque. And so what you see here, your healthcare provider will use a test to check for amyloid plaques. So there are two ways currently that we can confirm the presence of the plaque. Is that either through PET imaging, or through a lumbar puncture, where the doctor will take a little bit of the cerebrospinal fluid from your spinal cord and check for those amyloid protein. And this way, you have you know for sure that you have Alzheimer's biomarker. And that's what, again, following up on what Dr. Goldie was saying, that's the biomarker to confirm that you have this disease, in addition to the clinical symptoms. So how does Leqembi work? So Leqembi works is thought to work in two ways. A lot of the when we say how a drug works is based on preclinical studies, in animal research and in vitro. So it's thought to work through first targeting the harmful amyloid proteins before they aggregate and become really plaques. That's one. And second, it reduces the existing amyloid plaque that you see on the PET imaging. So it's thought to work in those two ways. Now I want to spend some time on this slide, which is basically how the clinical trial was designed and what was the result. I'll start with the result. What our clinical trial showed is that the treatment with Leqembi was proven to slow the progression of early Alzheimer's disease. It does not stop it. It just slows it. It slows significantly slows the progression of early Alzheimer's disease. And by doing so, it helps people remember, solve problems, and complete daily activities for a longer time in their lives. And like I mentioned, the way we know this is that the doctor and the people who are doing the clinical trials will measure those activities in specific tests for memory, for function, and for the activities of daily living. And all of those were kind of tested in an objective way. And how can we demonstrate whether a drug works? The way to do that is to compare patients who are on the drug to patients who are not on the drug, what we call a placebo. And all this is done in a blinded way. And the clinical trial that we did was 18 months. And it included 1,795 Alzheimer patients, early Alzheimer, so men and women. The age ranged between 50 to 90. And those patients, like I mentioned earlier, had mild cognitive impairment or mild dementia due to Alzheimer. And that's an important point that was mentioned earlier also, is that they came from different ethnic and racial backgrounds. And that's something that's very, very important in clinical trial. And even though I say here in our trial, it included a diverse population, it's still not enough to reflect the diversity in our society now. That's an area that we still need to do a lot of work. And this work can only be done if we approach it in a collaborative way, from the pharmaceutical industry that I represent here. We are running the clinical trial, but also with partnering with first and foremost you, the patients and the care partners, but also academic centers such as Emory and others. So it's very important. Not one group can solve can achieve this goal that we want. So like I said, the study was divided into two groups. So the group that took Leqembi, 889 patients, so kind of balanced, and the group that did not take the drug, or 897. So you compare the patients taking the drug versus the patients taking the placebo. And one thing I mentioned here, you may ask, those patients taking placebo, are they not taking anything, like not treated at all? It's not true. Actually, those patients are taking the usual medication that they take. And actually, many of them were taking symptomatic medications such as, Aricept or Memantine, other available symptomatic treatment for Alzheimer's. Those patients were on them as well. So that clinical trial allows you to see whether the group taking Leqembi demonstrate a significant improvement over the patients taking just, as of today, available drugs. And that's what Leqembi demonstrated. So I mentioned, I mentioned the groups taking the drug versus not the drug. I also wanted to mention here, and I added this actually to the slide, is how do we get to enroll such large number of patients? As you know, the previous speakers were saying, those clinical trials are very expensive, are very large, take a long time, and involve a lot of different centers. And so it involves a lot of collaborations between different people. So we try to work with centers such as Emory and others to ensure that we have adequate eligibility criteria for the patients, that we have the right site selections. We try to go to where the patients are to recruit for the clinical trials. We do a lot of, as well as the clinical sites such as here, do a lot of community outreach to go to the candidates and patients. So a little bit more about Leqembi and how it's administered. So Leqembi is an intravenous, so IV, intravenous infusion. That means that a needle is placed in the vein in your arm to receive the treatment, and it's delivered twice a month, so every 2 weeks. Every 2 weeks. So you may think this is a lot every 2 weeks. What we are working on is a subcutaneous formulation. That means it's a lot easier. It's comparatively speaking, that it's just a sub-Q injection that would be hopefully available in the future. Another thing to know is that each infusion takes about 1 hour, and that the infusion is administered at your healthcare provider's office or at an infusion center. And so you talk to your healthcare provider and, of course, insurance provider about where you can get those infusions. Now, again, from a safety point of view, it's very important to keep in mind that some serious allergic reactions can occur. They could include, but not limited to, swelling of the face, lips, mouth, tongue, hives, or difficulty breathing have happened during a Leqembi infusion. So, of course, when these happens, you have to talk to your doctor about it to address it immediately, or stop the treatment, or pause the treatment, or treat it for the next infusion. They're all available options. Some of the infusion-related reactions that are possible side effect, that could be a possible side effect with Leqembi, include fever, flu-like symptoms, so chills, body aches, feeling shaky or joint pain. Others are nausea, vomiting, dizziness, lightheadedness, or changes in your heart rate, or feeling like your chest is pounding. All of these can happen, in addition to blood pressure or difficulty breathing or shortness of breath. If this happens, you should tell the doctor or the infusion nurse if you experience any of these symptoms, and they would tell you what to do and what medicine can help in this, because these have happened. It's important to keep track of how you're feeling between the infusions. As I mentioned, it's infusion every 2 weeks, and to let your healthcare provider know right away if any of these events occur. Oh, sorry. So one, let me see. Yeah, it's one more slide. Okay, so a couple of things to keep in mind. I mentioned to you monitor your progress. One thing I didn't mention here is to understand the role of some genes play in your in the response to your treatment, and also in your predisposition to develop Alzheimer. One of these genes is called ApoE4. You may have heard about it. We can address it in questions. That gene, if you have it, you have a higher risk of ARIA. This is important to know when you're considering treatment, so you discuss it with your patients. And I'll move to my last slide, which is the Esai patient support. Esai provides some patient support. You can go to the websites here that have a lot of information that is helpful around, starting Leqembi, about how to get Leqembi, and also about insurance coverage for Leqembi. You can see the number here that you can call, but also you can go to our website, esaipatientsupport.com/Leqembi. I've also brought with me some of the patient brochure. If you'd be interested, you can grab one on your way out, or if there's no more, please contact us, and I'm happy to provide more. And with this, I'll conclude, and thank you for your attention, and happy to take any questions.
Okay, I think we're queuing up for Dr. Gillian. Dr. Laura Gillian is a professor of nursing at Drexel University, and she's going to talk about dementia behaviors and strategies to control and manage behaviors that are associated with people who have advanced dementia. And as soon as she finishes...
And I'm honored to be here for the 25th anniversary of Brain Health, and I appreciate the opportunity to report to you virtually as I was unable to come physically. And as Dr. Parker indicated, we're going to switch gears once again, and we're going to be discussing a very common clinical symptom of dementia that occurs at any point in the disease process, and really for any types of dementia. And I'm really looking here at kind of the functional consequences of having dementia. And as you've heard this morning, there's a lot of optimism moving forward for biomarker research and various treatments. And I would say the same in terms of in the case that I'm talking about, non-pharmacologic approaches to improving the quality of life when people do have dementia. So I'm going to talk a little bit about behavioral and psychological symptoms, and then I'd like to share with you one of our approaches, which is using therapeutically activity to reduce the risk for having these behavioral symptoms and how to manage them. I always want to acknowledge, and I'm very grateful for the many sources of support for the research that I'm going to be talking to you about that's been tested in multiple trials. And I also want to disclose that because of the success and the outcomes of the program I'm going to be talking about, which is called the Tailored Activity Program, we have developed an online program to train health providers in how to use this particular approach. And all the institutions I'm associated with and myself, we are entitled to some kind of royalty for that. But I actually wanted to start with a little poll, and I think I can see you now. So with a show of hands, I just wanted to ask, for those of you that are caregivers, has a health provider asked you or the person you care for about behavioral symptoms? And I don't see any hands. Has a health provider offered you non-pharmacologic strategies for managing behavioral symptoms? And I also don't see any hands. Has a provider asked if you are a caregiver? And I don't see any hands. So these are basic fundamental questions that if you are a caregiver, you need to ask your health provider for them to be engaged in with you. And it also speaks to the state of our treatment for people who have dementia and family caregivers. And for the health providers in the audience, do you routinely assess for behavioral symptoms in your patients or clients that have dementia? Any show of hands. And by the way, there are validated and many scales to use in order to detect behavioral symptoms. So I highly recommend that. Do you routinely provide strategies for managing behavioral symptoms? Do you ask whether your patient or client is a caregiver? So I don't see hands, and this is why I want to come back next year, the year after, so there are hands, because these questions reflect what we should be asking in a clinical encounter to be part of comprehensive dementia care. So let's start with what are dementia-related behavioral and psychological symptoms. These are scenarios, and you may recognize them. I'm not going to read them all. I could have filled the entire slide and had many slides of all the different kinds of common behavioral symptoms that can happen very early on in the disease trajectory. And as I said earlier, regardless of the type of dementia or stage. As a matter of fact, sometimes changes in personality, feelings of anxiety are symptoms that are noted by family members that do in fact trigger a diagnostic a search for a diagnosis. But very common scenarios: mother hears mail being delivered and opens the door and walks out trying to figure out what's going on. Father is restless, paces and walks aimlessly through the home. A wife follows, or what we call shadows, her husband around the home throughout the day. These are very stressful behaviors for the person themselves as well as for family members. So what are these behaviors? Well, this is an area that we're still trying to learn. There is continued research in this area, but basically they're a heterogeneous group of cognitive, behavioral, and psychological sequelae of brain disease. They are a consequence of what's happening in the brain and the buildup of amyloid and plaques and so forth that you've heard throughout the day. But they're not only a consequence of the disease, and I'll explain that in a moment. They also are referred to in various ways: behavioral symptoms, behavioral and psychological symptoms, neuropsychiatric symptoms, behavioral expressions, because they often reflect unmet needs. And I'm going to continue just to use the term behavioral symptoms, but the terminology is really rooted in philosophical as well as traditional professional fields, and represent different orientations of understanding these behaviors. But for our purpose, I'll just refer to them as behavior or behavioral symptoms. So the etiology is not well understood. Yes, of course, it is a consequence. These are of the brain disease. These are dementia-related behaviors. This, by the way, is something very difficult for families to understand. They often see some of the behaviors that you saw on the screen, on the slide before, as intentional. Mom never liked me anyway, and she's just refusing to have me help her even though she needs it. But in fact, the etiology is a consequence of multiple and concurrent factors as a result of the changes in the brain. But they may be due to pre-existing psychiatric illnesses, comorbid medical conditions, an increase in pain. Certain medications have behavioral outcomes, delirium, and a variety of unmet needs in the person with dementia, such as sleep, hunger, boredom, loss of control, anxiety. Also, we know that the way in which a family member and care providers communicate with the person can impact behaviors. Often our communications are overly complex because we don't have a good understanding of what the person living with dementia can do or not. And obviously, abilities keep changing from morning to night, so it's very confusing. As caregivers, our own stress and poor health can also affect the emotional climate in the environment, which can also contribute to behaviors, as well as physical environmental factors. An environment can be too overstimulating, such that the person becomes restless and aimless and paces, etc., or it can be understimulating. We know that boredom and withdrawal from activity often contributes to different kinds of behavioral symptoms. It can be too hot or too cold. So these behaviors are complex, and they're a consequence of all of one or more combination of these kinds of features. So more formally, these behavioral symptoms have been grouped into these different categories. These are very broad categories, but they're a way for us to think about them and also then to develop different kinds of treatments. So agitation is the biggest grouping, if you will, of behavioral symptoms that often occur very early on with the disease, as well as throughout the disease progression. Aggression, apathy, depression, and psychosis. Agitation has to be unpacked, because if a person's agitated, that doesn't tell you too much. How does the agitation manifest? Is it rejection of care, restlessness, aggression? And all of these kinds of forms of agitation can co-occur. The loss of ability to relate to a partner and have empathy is a major, major challenge in some dementias versus others, such as frontotemporal dementia, and it becomes more upsetting than other types of behaviors, particularly for spouses. And interestingly enough, although there's been a lot of drug discovery in this area, hallucinations and delusions do not occur as frequently as these other behaviors of agitation and aggression. And when they do occur, they may not be upsetting to the individual or family members. Here are the behaviors that caregivers in a trial of 239 families identified as most upsetting to them: repetitive questioning, arguing, toileting, upset in general, rejecting care, waking at night. So families and individuals with dementia view these behaviors as occurring most frequently and most upsetting. Here is another survey of family caregivers in the COPE program in a trial in Connecticut, and you can see the range of behaviors. CR stands for care recipient, repeating questions over and over again, anxious, worried, fearful, waking up at night. These are all different: agitation, arguing, aggression. These are all different kinds of behaviors that families identified as most distressful to them. What's important to recognize is that there isn't one behavior that happens, and there isn't one behavior that's most upsetting. So this is a highly personalized experience, if you will, and different kinds of behaviors will be occurring in different care situations and be relatively upsetting or not to families. But the one important point to know about these behavioral symptoms, and the reason why I asked you those questions initially, is that these behaviors are bad for everybody. They have multiple negative outcomes for the person who's living with the dementia. There's been some really important work shown that having behavioral symptoms that are not addressed, either pharmacologically or non-pharmacologically, actually leads to more rapid cognitive decline. It's associated with more hospitalizations, poor quality of life, and rejection from care facilities. Having behavioral symptoms that are extreme aggressiveness towards a staff member will have a person living with dementia hospitalized or kicked out of that facility. Also, there are negative sequelae for family caregivers. Having to manage behavioral symptoms is associated with having to provide more care and increase distress and upset and depression among family caregivers. It is a trigger for relocation or residential placement, and it increases costs for the family as well as for society at large. So these behaviors, which are common to the dementia experience, really need our attention. And so the question is, how can we manage, how can we prevent, and how can we manage these symptoms? And today, the current treatment is such that I think if the poll was accurate, behaviors are underdetected and undertreated. And current medications, which include some anti-anxiety, antidepressant, and psychotropic medications, have been shown to have limited utility. That's not to say they can be helpful for some families, but in general, they're not the first line of treatment. As a matter of fact, medical associations have all recommended that what we call a non-drug, a non-pharmacologic approach be the first line of a treatment. And it has to do with understanding what may be some of the factors that are contributing to the behaviors, such as, is the person hungry or too cold? Or are they really scared and not feel a loss of control? Are my communications as a caregiver too challenging? All of the things that I just mentioned can be modified and changed. And that's the first line of treatment here for behaviors. So I want to tell you about the Tailored Activity Program because we're really excited about it. It's now considered an evidence-based program, and it's been shown in 9 different studies to improve quality of life for people living with dementia and their caregivers. And I'll call it TAP for short. TAP introduces activities, and this is what's really critical. It's not any activity. The activity is tailored to what a person can do still, regardless of the stage of the dementia, and what their interests are previously, their previous occupation, the objects that they used to work with, and also their current interests. And then we instruct family members or providers in how to set up and use the activities on a daily basis. And also we provide dementia education and stress reduction techniques for caregivers, because it's really important to create a calm environment for the conduct of activities. Excitingly, this is a program used in 11 countries. We've trained over 320 health providers in 8 different settings. And in the United States, it's been a little slower rolling out, but here are some of the states that have gotten funding to train their health providers. The VA in Pennsylvania is rolling out TAP throughout the VA geriatric home care setting, just to give you an example. TAP has been adapted and tested in different care settings. It was initially tested in the home. It's been tested in hospitals, adult day services, and in residential facilities. So we've developed an approach that can be implemented in various care settings. But you may ask, well, what is activity, and why bother with activity? It doesn't sound as profound, perhaps, as a drug treatment, but it is like a therapeutic. It is a therapeutic, and sometimes I call activity like a pill. And why? Well, we know from many studies that engagement, regardless of level of impairment, type of disease, and age, is incredibly important throughout one's life and is associated with life quality. And that is the case in people living with dementia. We know that a lack of activity is actually associated with boredom and having behavioral symptoms. We know that providing activity, regardless of the stage of the disease process, except possibly, of course, in the very end of a person's life, provides a sense of purpose, roles, and connectivity. And these are enduring needs that we often ignore when we think of dementia care. We also know and have shown that activity that's meaningful and meets the person where they're at, provides relief from situational stress and anxiety. This needs further testing, but we believe too, and have some evidence in other types of studies, that activity provides some physiological benefits. And maybe the most important is that it really matters to people. Being engaged, having a sense of purpose and a role which activity provides, it really matters to people. And we see that in various surveys. This again is a survey from my colleague, Dr. Fortinsky's research in Connecticut on one of our studies. And he shows that activity, whether a person is living with a person living with dementia or apart, was one of the most important challenges they faced. What kind of activity can I give my loved one? And this is particularly true for those people, caregivers who are living with the person. So it's very, very important and rates right up there with other kinds of needs. Similarly, a survey of a needs assessment conducted at Hopkins with 303 dyads showed that 51% of respondents indicated the lack of meaningful activities as their primary concern. So this is what matters. So how does TAP work? First, it involves a very novel assessment of the interests and roles, previous and current, of a person living with dementia, their abilities, an assessment of the caregiver, their readiness to use activities, their availability, their communications, their daily routines, what is considered an appropriate activity, their employment and other roles they may have, an assessment of the physical environment for its lighting, seating, the number of people in the household, the kind of noise level, etc., and putting it all together, creating what we call an activity prescription that will look different at different stages of the disease. And I won't go through all the details of how these activities differ due to the time. In phase 2 of this program, this is very critical because caregivers, whether they are the home health aide, the family member, the recreational therapist in a hospital setting, learns what a person can do, not just what they can't do, but what a person can do. We can create a meaningful activity for someone with a 0 mini mental status, cognitive status. So caregivers learn the abilities of a person. They learn to relax the rules. It doesn't matter if the person does something right, plays the card game right, puts the block in the right hole. It doesn't matter as long as the person is engaged. And we teach different kinds of cueing techniques, etc. And then the caregiver also learns how to de-stress, take time for themselves, and make adjustments to the activity as needed, and then also how to use the strategies that we show in terms of communicating, in terms of helping a person initiate an activity to manage other kinds of care challenges as well, because the way in which you set up activities is relevant to other kinds of care tasks that need to be done. And here are just some examples of activities for a gentleman who maybe you can guess he was a carpenter, and he is has a moderate to severe stage of dementia. And this is an activity board composed of objects that, as a carpenter, he was and a plumber, actually, he was very well versed in, and he derived great pleasure. You may guess that this woman, let me go back. This woman is a librarian, so she enjoys very much working with letters and words. And this is and again, she had a mini mental status of 2, where most people understood only deficits. But here is a person that could be engaged in objects that are meaningful to her. And here is a more advanced game of dominoes, if you will, for someone at at a higher level of cognitive status. I wanted to show you what this looked like from, this will switch in a moment, so you'll see in a minute. And this is from colleagues in Italy who provided an activity to this woman who was in a care facility because her sons had to put her in a care facility because of her extreme anxiety. And you won't unless you speak Italian, you won't understand this, but you will get her sentiment. So I'm hoping this works. Here we go.
Allora hai capito? Come fai che tu aspetta lei, allora ho che ti un match a sì o che da minchiare. Dai, ma vedo un po' padrone.
So she's screaming, and she is screaming obscenities and insults. The staff were very scared of her. This was one of her first nights in the facility, and she wanted certain things done and in her way, and she became extremely agitated. They immediately gave her some medications to calm her, but they brought in also the health provider who we had trained, and he studied the situation. And what he learned is the staff were speaking a dialect that she didn't understand. He also learned that she was a homemaker, and she also used to clean and fold clothing from everybody in her village. And she was looking to straighten out and arrange that table that you saw in a way that made more sense to her. And she couldn't understand what people were talking about. So what this health provider did was got her off the meds, introduced activity, and she eventually got off the meds, but he introduced folding activity. He gave her all different kinds of uniforms, etc., to fold, and taught the staff, I'm going to show you this video, and taught the staff how to communicate with her. You see here her intensity of concentration. She has a very low mini mental status of about, I believe, under a 5. Yet she's able to manage objects that she's very used to. She's very engaged. She calmed down immediately, even when people were passing by her. And she was able to get off of her medications. And after this, the entire unit was given the tailored activity program. I just think this is a dramatic showing of what activity can do when it's also paired with training of providers how to communicate slower, calmly, and not to touch her or move her around, which she did not like. So through various trials, we have shown that caregivers actually do have to help set up activity, but they gain more time. They express more, better, improved caregiver well-being. They have more confidence in their care approaches because they understand better what the person can do and what they can't do. For the person living with dementia, we have been able to reduce behavioral symptoms, in some cases, eliminate them completely. We can reduce over a physical dependence for at least a short period of time, which a drug has yet to be able to do. And we also show that by using activities consistently, people living with dementia and caregivers have fewer health events, therefore leading also to cost savings. And I'll just show you this data, and I'll be concluding in a moment. But in one trial of 250 dyads compared to a group who got attention control, meaning that they received a very intensive education program, we found that people living with dementia had much fewer hospitalizations. Caregivers had fewer hospitalizations. Caregivers had less depression at 4 months. And we were able to reduce overall health events by 32% through this program. When caregivers, family caregivers used TAP at home, they reported increased pleasure somewhat or very much in the person living with dementia, a decrease or no sign of anxiety or upset, and no sign of agitation or very little. We also found very interesting differences in the impacts of TAP on different groups. And this fancy chart is merely showing that caregivers who identified as Black, who received TAP, compared to Black caregivers in our control group who received education, and compared to their white counterparts, reported significant reduced agitation and aggression in the person they were caring for. And in our caregivers who identify as white, those who received TAP compared to our African American groups and our control groups, they experienced reduced depression over 3 months, whereas our attention control group who received education increased in their depression. And our African American sample started with no depression. They really had nowhere to go in terms of this particular outcome. But we are always looking for what are the specific effects of any of our interventions. We also studied a group of 20 people who were hospitalized for these behaviors, and we introduced a standard activity. If you've been in a hospital, it's pretty boring, nothing to do, it's confusing, and you're just sitting around. We introduced a simple magazine. We gave the same magazine to everybody, but then we compared it to the TAP approach. And what we found is, and I think these may be a little confusing, so I'm just going to explain what you're looking at. Everybody improved by just getting a magazine to look at. They had something to do in the hospital. Their behaviors improved. They experienced pleasure. That's this group. Reduced anxiety, and some anxiety and anger were still there, and negative verbalizations. But if you provide an activity that's tailored to a person's interests, what you see is a more increase in pleasure, a higher decrease in negative kinds of aggressiveness, and a dramatic decrease in anxiety and anger. So any activity is great. Tailored activities are amazing. So in conclusion, behaviors are common dementia-related clinical symptoms. They're undertreated, they're underdetected, but they can be prevented or managed. But it does involve a non-pharmacologic tailored approach. Activities tailored to abilities and interests really benefit everybody, the person themselves, the caregiver, and society because of cost savings. Caregivers learn, very importantly, what a person is able to do regardless of, at every stage of the disease, and then how to use activities. And meaningful activity can even reduce hospitalization and health-related costs. So it's a pretty important therapeutic benefit. And with that, I thank you so much for your attention and the honor of being able to share some of this important work. Thank you.
Okay. Dr. Samad and Dr. Gillian. Dr. Gillian, this question is for you. You talked about the tailored activity program and where it was available. Is there any opportunity for that to come to Georgia?
Yes, well, thank you so. Yeah, thank you so much. This is such it's such a difficult challenge to take evidence, whatever the evidence is, for drug treatments as well as non-pharmacologic, and push it out. But we are set up for training, and I would urge you to refer any health provider to our training, and we'd be more than happy to train them in TAP. Right now, Georgia, I did check, does not have any folks who are trained. And I would say the closest thing to having the tailored activity program would be to have a referral to an occupational therapist who is dementia trained because of their special background in being able to set up activities. So if someone is not trained in TAP, I would say, well, send them our way, of course, but also that would be a referral to an occupational therapist who has really helped me and my team advance this program.
Thank you. Thank you for that answer. So, occupational therapist for managing behaviors of people living with dementia. Dr. Samad, you have a question? I think it works. It should be on.
Yeah. Yes. So there's a couple of questions, actually, all great questions. Thank you. So first one is Aricept still being used for AD? So Aricept, cholinesterase inhibitor. Actually, it is. So like I mentioned in my presentation, a lot of the patients included in the trial were on cholinesterase inhibitors. Of course, the way it works, it's different from the way Leqembi works. Aricept works on the symptoms. Leqembi works on the underlying pathology that is believed to cause Alzheimer, which is the amyloid protein.
Okay, Dr. Gitlin, one of the things that you talked about, non-pharmacological, without medicine, behavioral change. A lot of hospitals, a lot of assisted livings like to use medications to control behavior. Can you tell our audience why this is not a good thing?
Yes, I think for two reasons. I would say that the use of medications for behavioral management is really a knee-jerk approach. As you saw with behaviors, they're very particularized. They occur due to multiple factors, and the medications are not designed to address those factors. So in some cases with extreme aggressiveness or agitation, there are some medications that can be helpful. But the point and the why this is so complex is that it's very important to go through what we refer to as a problem-solving approach as to why a behavior may be happening. Are there particular triggers that are related to the person living with dementia, the caregiver, or the environment that then can be mitigated or removed? And that's just not how our health system is set up, honestly, to treat issues. So often it's a knee-jerk reaction to give a med without really fully exploring the context in which a behavior occurs. And just one other thing, Dr. Parker, a behavior in my household, like my father trying to leave the home, may look very different than someone else's household in which their mother is trying to leave the home. The triggers may be very, very different. This adds to the complexity of treating these behaviors and why we have to uncover different patterns for why they may be occurring. And just providing a medication will not do that in and of itself. Thank you. Dr. Samad?
Yeah, so we got a couple of questions around how long to treat. Is the infusion forever? It's a great question, and the short answer is we don't know. The clinical trial itself was for 18 months, so that's as much as we know. There's ongoing now open label extension with the study beyond 18 months, so we will get more information around this. So, you have to keep in mind that this is a progressive disease. It continues. So, but the actual, decision to continue the treatment beyond the 18 months is something that you will have a conversation with your, with your doctor. But that's a great question.
Do you have another question, sir?
And I have also one actually very important question is, do pharmaceutical companies, and I guess you're referring to our company, provide any help with access to the drug? that's approved. Actually, yes, we do. And you saw on my last slide the link to the patient access, patient services. They definitely provide help. That's not my department, but you could see they provide you with they connect you with a patient navigator who discusses with you your case from a coverage point of view, and provide also, there's the possibility to provide some assistance for patient in need, financial assistance with the copay. So the other part of the question is a little trickier, is, if I understand correctly, is assisting in providing medication for drugs that are not yet FDA approved. So that's a little bit tricky. Usually the way to have access to drugs not yet approved is to participate in clinical trials. That's the best way.
Okay. Are there any more questions for Dr. Samad or Dr. Gitlin? Okay. Thank you, Dr. Gitlin. Thank you, Dr. Samad.
Thank you.
Thank you. Thank you very much.
Thank you. This concludes our formal presentation. At